So assuming, let me pick on maybe each of you to color how you use EGFR therapy in metastatic colon cancer today. So we'll give everybody wild type RAS. So pan-RAS, the right test, it's the right patient, metastatic, and we'll make unresectable disease. Okay, so we're not going to go after resection and the like. Marwan, where would you put EGFR cetuximab therapy in the line of therapy? Are you a FIRE3 kind of guy where a frontline maybe survival benefit of 30-something months, or is it save it until later because of rash and toxicity?
Sure. No, I mean, I think until recently I have been saving it till later, but I have to say I think it's compelling. The data is compelling when you look at PRIME, when you look at FIRE3, when you look at PEAK, and now when we look at SPIRIT this meeting, that the differential of improvement is increasing with the RAS wild type signature. And I think the other message that I take from FIRE3 is, yes, you have a certain same percentage of patients getting second-line chemotherapy, but there may be a differential benefit from anti-angiogenesis therapy versus anti-EGFR therapy along your lines of treatment. In other words, if you miss on anti-angiogenesis, during your whole treatment duration, it may not be as important as missing on an anti-EGFR treatment. And not every patient on the FIRE3 who is progressing is getting anti-EGFR therapy. And it's possible that you miss on treating patients, and maybe you want to move your effective therapies up first so that you don't miss on them up later. Patients do progress. Most of them are not going to become eligible for second, third line. So I have to confess, I have moved anti-EGFR therapy a little bit up front in my practice. I do discuss the side effects with patients, but I'm typing all patients up front, and I am moving anti-EGFR therapy to the first line treatment.
You've got us confessing. All right, another confession.
Okay, I'm going to confess I don't. Point counterpoint. So to be honest with you, I think right now it's intriguing data, like Alan said. It's one study that was potentially flawed in design, that we still don't have all of the information, and that we can't quite explain. Now, I think that there's other smaller studies as well that may be suggesting this, but again, smaller studies. I think right now I'm really curious to see the results from 80405. And this is the study that Alan hopefully will be presenting at ASCO this year, because I think that that's going to help us understand a little bit more about bevacizumab versus cetuximab in the first line. People will argue, because most of the patients on the 80405 study had FOLFOX rather than FOLFIRI as the chemotherapy backbone. But I think that still, if we don't see a clear winner, and the survivals seem to be panning out like we're starting to hear rumors about a very long survivals on 80405, that actually come right into play with where the FIRE3 survivals were, you know, I might just continue to hold that rash-causing drug till later.
So you're holding.
Yeah.
So for me, FIRE3 changed, but not necessarily in the use of EGFR receptor inhibitors, but in the patient population where I use it. Because I was always believing in the data, conversion of resectability and high response rate. Now, the response rate were high, but not significant different. So I was shocked that my belief in how EGFR receptor inhibitors work did not reflect the difference. So, but I am intrigued by this 7 month, because when you look at all the data, if it's PEAK and PRIME and the upcoming data on OPUS and CRYSTAL and now in FIRE3, I think you need to test and you need to consider this as a treatment options, discussing with your patients. I think you cannot just ignore it. Does not mean everybody patients get it. There are a lot of different balances to discuss. Toxicity is one of the major issues, but I think I discussed this option in first line.
Yeah. Alan, you have to probably be objective here, because
that's
you're
hard
the
for me to
PI
do.
of the study that may answer our question. Where are you right now in clinic today?
Well, so I actually about a year and a half ago, I gave a discussion at ASCO about, at the time, TML and a couple of other studies.
I remember it well.
Treatment.
Yeah, me too.
Are you one of the people who sent me the nasty email?
One of the many, yeah.
Where I said at the time that I didn't think bevacizumab should be used up front was a take-home message, because of the biological observation from TML and perhaps others, that when you withdrew the anti-angiogenesis drug, there might have been a rebound effect, or you gave back what you got. That was speculative. I was stirring the pot at the time. But in fact, I don't use a biologic up front for many patients. A year ago, I would have said for a curable patient where I needed a big response in the liver, let's say, to convert or to minimize their metastatic disease, I would have used an EGFR antibody. Now we, of course, have data talking about giving and taking back that suggests that cetuximab or an EGFR antibody in the curable liver resection patient is not favorable. So the truth is, as Johanna said, I don't know what to do. I wouldn't dare tell a patient I don't know what to do. But I do think 80405 will be incredibly important. Johanna hit the nail on the head. The majority of patients are treated with FOLFOX, so it won't be directly comparable to FIRE3, but it will give us an important message. And it's true that the survival looks extraordinarily long. You could deduce that by knowing that it closed 2 years ago, and we still don't have a release of the data.
Heinz, I mean, this is a perfect